Hi. Today I am starting a series of discussions about prostate cancer. In most of cancers, we have a standard type of staging that we call T and M staging. T stands for tumor, N stands for lymph nodes, and M stands for metastasis. And generally, depending on the type of cancer, we take factors such as size of the cancer, what layers of the tissue it has involved. In some instances, the measurement of depth of invasion of the tumor. Depending on cancer, we assign different T stage to that type of cancer. For N, that representing lymph node, usually we assign N stage to a cancer depending on whether lymph nodes have been involved or not. Sometimes the number of lymph nodes, sometimes the size of lymph nodes, sometimes whether lymph nodes that are involved are on the same site that the cancer has showed up, or the opposite side that we call contralateral. Often we have what is called regional lymph nodes, meaning that anatomically, for each organ, there are certain lymph nodes that normally drain from that particular organ. And if cancer involves lymph nodes that normally are not associated with that organ, and that would be called non-regional lymph node metastasis. Sometimes that would go into the staging of M, which is metastasis. And M, as I mentioned, is about, most of the time, not always, it's about distant metastasis. But sometimes we, as I said, we may consider a lymph node that is not regional to that particular cancer as M staging. And sometimes, depending on the type of cancer, we subdivide M staging to M1A, M1B, M1C, depending on what areas or what organs it has involved. What is the purpose of staging? The purpose of staging is that we want to determine what is the appropriate treatment for different individuals who have different stages of that cancer. Treatment's not always the same for stage 1, 2, 3, 4. And so it has the value that we can refine treatments or standard of care for each stage of the cancer. It also obviously has a prognostic value, meaning that often it is associated with statistics of possibility of surviving that cancer, risk of cancer coming back. So it has a prognostic value. Now, if based on research and experience data, we can further refine cancer, meaning going beyond staging, then we would, because the more precise we get, the more we can refine these stages and different situations for each patient, the more precise we can be in terms of, number one, predicting or estimating their chance of survival, cure, risk of recurrence, and tailor treatments even further, depending on these refinement of risk factors and prognostic factors. One of the cancers, which is the topic of today's discussion, prostate cancer, mainly instead of relying solely on the stage of cancer, we use a number of tools to further refine prognostic or risk group of different patients. I name a few, but today I would not be able to review all of them. For example, in prostate cancer, in addition to stage, we categorize PSA, which is prostate-specific antigen, which I will talk about it more. And depending on what is the level of PSA, we define different risk groups. We also pay attention to the pathology or what a pathology sees under microscope based on biopsy or surgery. And there is a specific term that is only used for prostate cancer, and that is called Gleason Score. And I will talk about that today. We also use molecular analysis, biomarkers, genetic testing that can further refine these risk groups. We sometimes use the statistical models. They are called nomograms, and perhaps this would be discussed in the next session. Not for prostate cancer, but there's another term used for some other cancer called recursive partitioning analysis, or RPA, or graded prognostic assessment, or GPA. These are, again, statistical models that we use based on data, looking at who does better, who does worse, and take into account many factors, often not related to the cancer itself, but the whole patient in terms of their performance status, in terms of other comorbidities or other issues that they might have that may make tolerance of treatment difficult for them or easier for them. Sometimes their age. So we use a number of different factors. And the goal is really not to make this more complicated than staging. It's really, the goal is refinement. We want to really, instead of saying, okay, prostate cancer as a general term, we really want to refine this into different diseases, because these are different diseases, and meaning that prostate cancer can be molecularly different, could be biologically different, could be different by stage, could be different by Gleason score, by PSA, and many other factors based on data. And the more we can refine different stages, different risk groups of prostate cancer, the better we can individualize treatments for the patients. And by individualizing treatment and personalizing treatment, we can not only exclude the treatment that are over treatment or under treatment, and as a result, if a treatment is not necessary, don't subject patient to the side effects of that treatment. And if in more aggressive forms of prostate cancer, if more needs to be done, more needs to be offered, then we offer more. So treatments are tailored based on the risk assessment and prognostic factors. So starting with PSA, as I mentioned, PSA is a prostate-specific antigen, and it's a protein that only prostate gland secretes. And now there's a normal range for PSA that is usually up to 4, but I have to emphasize that as gentlemen age, their PSA level increases. So these levels are not written in stone. They have to be individualized. When we see somebody who has a PSA between 4 and 10, which is usually the area that we use further analysis to see whether we need to go further, take biopsy, do imaging, or we can just observe. We take age as a factor. So if a 40-year-old has PSA of 4.5, we have a different trigger, if you will, or threshold compared to somebody who might be 65 years old. We also look at their family history, their race. What is the likelihood that this person statistically may develop prostate cancer? And we take all of those into account. But a simple analogy that I want to use is like an orange. So if you have 2 oranges, and each one of them, after you juice them, produce a certain amount of juice, obviously, you can't compare them if their sizes are different. So if you have a big orange, naturally, if the quality of both oranges are the same, you get more juice from the bigger orange compared to a smaller orange, which naturally you anticipate to get less juice out of it. So when we want to decide whether somebody based on their PSA needs further workup, such as biopsy, another factor that we take into account is the size of their prostate. One of the reasons that PSA level increases with age is that usually we have something called benign prostatic hypertrophy, or BPH, meaning that the prostate in older gentlemen is usually larger, and often it may cause symptoms such as frequency of urination, getting more frequently up at night, which we call it nocturia. They may have urgency. Sometimes the opposite. They have difficulty emptying their bladder. They call it hesitancy. But it has nothing to do with cancer. It's benign. It's a benign process. Now, if somebody has a large prostate gland, obviously the PSA is going to go a little bit higher, because just like in analogy oranges, now you have a bigger prostate gland. So the term that we use for this is called Psa density. And what it means is that with an ultrasound that is done through rectum, we measure the volume of the prostate gland in an individual, in a gentleman, and then divide the PSA by the volume of the gland. And that ratio basically eliminates the difference between sizes of 2 prostates. So that's one way to figure out whether this increase in PSA from last year to this year has anything to do with the size of the prostate or no. Maybe it's a sign that there is some kind of cancer beginning in the prostate gland. The other terms that, or methods that we use to basically further refine the group of patients that have a PSA of 4 to 10 is by looking at what we call free and bound PSA. So the PSA in our blood, part of it is free, is unattached to anything else, and part of it is bound, which means that it attached to another protein. When you look at the ratio of what we call free PSA, that is the PSA that is free floating in the blood and it's not bound, when you measure that ratio to the amount of PSA that is bound, the higher the ratio is, meaning that the more we have free PSA, the better, meaning that it is less likely that somebody has prostate cancer compared to somebody's whose ratio of free to bound PSA is lower. The cutoff is controversial, but it's about 25%. So when somebody has a PSA of 4 to 10, is falling in the group that we're suspecting, do we need to do further workup? We look at these things. We look at Psa density. We look at ratio of free to bound PSA. We also look at the history of PSAs that have been done every year. That is, if the gentleman has been compliant with prostate cancer screening, which requires starting to get a PSA level as of age 50. This is in average risk group gentlemen. If somebody is at a higher risk group because of family history or genetic testing or anything like that, it would start earlier, sometimes as early as age 40, at least for having a baseline. But the reason that is important that a gentleman does PSA every year, that then we can look back and look at the pattern and see whether over the years PSA has been stable or has been increasing. So here comes a couple of more terms that I want to introduce to you. You might have heard about it. One is called Psa Velocity, and that simply means the speed with which PSA has been increasing when you look at previous years. Obviously, the higher the speed or higher the velocity, the more concerning it would be. On the same token, we also have a term called Psa Doubling Time, and that specifically means the duration of time that PSA has doubled. So say somebody started at age 50 and PSA was 2. And then now they are 60 years old and PSA is 4. So the doubling time for this is 10 years, right? Because it has taken 10 years to go from 2 to 4. And again, when the shorter the doubling time is, which suggests higher velocity and higher speed, the more concerning that would be. So the other factor that I want to bring your attention to is that a prostate gland is very sensitive to inflammation, to infection, to any other form of stimulation. And a prostate gland that is inflamed or is infected or has been stimulated produces more PSA. So, for example, we ask for a gentleman who is scheduled to have a PSA drawn, blood test, not to have sexual activity within 48 hours from doing the blood test, not do vigorous exercises, especially the ones that put some kind of pressure or compression on the bottom of the person, like we're closer to the prostate. Say somebody bikes, that obviously kind of massages the PSA, prostate gland, and it may give you a false higher reading. People who have infection or inflammation, for example, a gentleman who is in the middle of his radiation treatment for prostate cancer, we don't check PSA then, because prostate gland is inflamed as a result of the radiation they're receiving. And we often wait about 3 months or so after they complete their treatment before we check their PSA to see the effect of radiation, whether it has been successful or not. So these factors are important. Because of that, we really don't rely on one PSA. If a PSA is concerning us, we have seen a significant rise or something like that, we may repeat it. We may look into whether that gentleman had a recent infection, or before doing the PSA test, engage in vigorous exercise or any factor that can cause a false rise in PSA. So with just one rise in PSA, we don't jump into getting a biopsy. So we look at all these factors. In terms of Gleason score, you may not know that one of the most helpful and the most important specialists that you don't even see often because they are behind the scene, but their job is extremely important, are pathologists. Pathologists are physicians who have specialized in looking at different tissues under microscope and making determination on whether this, for example, tumor is a benign tumor, whether it's cancerous, if it is cancerous, what type of cancer it is. They often assign a grade. They often, if they have the entire tissue after a definitive surgery, they assign pathological TNM, tumor lymph node metastasis. And that is really where an oncologist, radiation oncologist, or medical oncologist, that is the basis of our stratification of staging and risk group, and it really determines what kind of treatment we would offer. So if we got suboptimal diagnosis or reading by a pathologist, that's really a bad start, because our decisions are based on that. And if the diagnosis is not right or risk stratification has not been done correctly, the whole direction of treatments would take the wrong turn. Many academic centers, if you go there for a second opinion, if you go with a pathology that was done in an outside institution, they may want to have your slides or block of your tissue from the outside pathology. They may request it because they want their own pathologist to take a look at it. And that's really for the purpose of consistency in their institution, because they want to make sure that trustworthy pathologists are reading their pathology, because as I said, that's really the baseline of any further action or treatment that we recommend. So when it comes to prostate cancer, as I mentioned, we have a term called Gleason score. Gleason comes from the last name of a pathologist who noted that in prostate cancer, there are different patterns of cancer, and they number that based on the first or the most dominant pattern, followed by the second dominant pattern. And the way that they number them, they use scores from 3 to 5. And they would assign 2 numbers as I mentioned, for each cancer they look at under microscope, they assign two numbers. The first number is the most predominant pattern, and the second would be the second most prominent pattern in that cancer tissue. And then it would be presented in the report as two numbers with a plus in between them. So if the most predominant pattern is 3, and the second most predominant pattern is 4, they would say the Gleason score is 3 plus 4 equals 7. Now, if another cancer, they saw that the most predominant pattern was 4, followed by the second most predominant pattern, which is a 3, they would give you two numbers, 4 plus 3 equals 7. But these two 7s are not equal, because the most predominant pattern in the latter one was 4, and the most predominant pattern in the first one was a 3. And this makes a difference in terms of how aggressive the cancer is. So usually the one with 3 plus 4 is considered more favorable, and the one with 4 plus 3 pattern is less favorable, higher risk for recurrence or distant metastasis, therefore treatments would be different. But that would not be the only factor we take into account. We take into account PSA, we take into account Gleason score. We also take into account, generally biopsies are 12 core biopsies. So there's 12, if you divide a prostate gland into 12 regions, up and down and front and back and side to side, they would get a sample of one of each of these regions. So they have 12 core biopsies. So now we pay, the pathologists and we as oncologists pay attention to, number one, how many of these cores were involved with cancer. So if somebody had 12 core biopsy and only 2 of them were involved, their prognosis is better than somebody who had 12 core biopsies and 8 of them are involved. Because when you have 8 out of 12, it suggests a relatively higher volume of disease. We also pay attention, and that is another piece of information that a pathologist would give us, as what is the percentage of each core involved. So say we have 2 patients, each one of them have only 2 out of 12 cores involved with cancer. But one of them, the 2 cores, one of them is 20% involved, the other one is 30% involved. And the second patient, who again has only 2 out of 12 cores involved, percentage of involvement of each core, the first one is about 50% and the second one is about 70%. So even though they might have, both of them might have the same Gleason score, they might have the same PSA, they might have only 2 out of 12 cores involved, the patient who had 50, 60, 70% of their cores involved has a worse prognosis than the person who has only 20, 30% of their core involved, because again, the latter suggests higher volume of disease. So what is the PSA ranges that we pay attention to? If PSA is up to 10, usually that is considered lower risk. If it's 10 to 20, we call it intermediate risk. And if it's 20 and higher, we consider it high risk, just by looking at PSA. Now, by looking at Gleason score, we consider Gleason score of 6 to be relatively lower risk. If it's 3 plus 4, we call it intermediate, but favorable intermediate. If it's 4 to 3, we call it less favorable or unfavorable. And once we get to 4+4 or any component of 5, then those we consider high risk. But our stratification is not just based on PSA, just based on Gleason score. We combine all these risk factors, number of cores involved, percentage of cores involved, Gleason score, PSA, and have several risk groups from very low risk group to very high risk group. That I will get into more details of it in the following sessions. I have to emphasize that this Gleason score stratification that I talked about only applies to adenocarcinoma and squamous cell carcinoma of prostate. We have others forms such as sarcoma or transitional. It doesn't apply to them. It applies to adenocarcinoma and squamous cell carcinoma. So then when we go to the TNM staging for prostate cancer, TNM staging for prostate cancer is not only limited to T, N, and M. They have also introduced PSA and what is called grade group, depending on the sum of first and second dominant patterns in Gleason score and total sum, and T stage, and N stage, and M stage, and PSA. We further refine staging of prostate cancer. But generally speaking, if somebody has prostate cancer and they go to their doctor, after taking into account all the factors that I spoke about today, then we assign them to, as I said, very low risk group, low risk group, favorable intermediate, unfavorable intermediate, high risk, and very high risk. And depending on which of these groups they fall into, we make recommendation in terms of their treatment options. And obviously, the lower is the risk group, the more options the patient has, and the higher the risk group, the less option they have. And by that, I mean, generally speaking, for example, surgery is not offered to people who have high risk or very high risk, because then there's a good likelihood that despite surgery, they may need radiation. And we often we don't choose to expose them to both surgery and radiation, even though with the best of our effort in terms of stratification, these are just statistics. So we may consider somebody to be low risk or favorable intermediate risk, and surgery is offered to them, and they go, and the whole tumor cannot be removed. That situation is called having a positive surgical margin, meaning that instead of surgeon cutting beyond the tumor, they have cut through or at the edge of the tumor, meaning that we don't know, is there more cancer left in the body? And in a situation like that, then we may offer them additional treatments such as radiation therapy. But obviously, if somebody had only surgery, they would be at risk of getting side effects of surgery. If somebody only got radiation, they would be at risk of getting only side effects of radiation. But if they got both of them, they are at risk of getting both side effects, and that is not really ideal. So, as I mentioned, we also use for prostate cancer a statistical model to make an educated guess on what is the likelihood that the lymph nodes in their pelvis could be involved. That is taken into consideration both before offering them surgery and before offer them radiation therapy, because when I say radiation, depending on what stage they are, what risk group they fall into, our targets will be different. So do I need to treat the pelvic lymph nodes or not with radiation? Depends on that educated estimate that we make by using these nomograms that I will talk about next week. And if the risk is less than 15%, usually we don't treat. If it's more than 15, we do treat. And like any other part of medicine, we always weigh benefits versus side effects. And benefits must outweigh the side effects before we recommend a treatment. Obviously, if treatment side effects are going to be higher than the benefit patient would get, we may not offer that treatment. So the other factor that I will talk about are molecular analysis, biomarkers, genetic testing that is done now for prostate cancer, which measures, or maybe not measure, estimates, again, educated, scientific estimate on what is the risk of this person having a recurrence after whatever treatment they have offered them, surgery, radiation. And based on the risk, we, again, stratify. Two gentlemen might have exact PSA, exact Gleason score, exact stratification based on TNM and PSA and grade, but when they both get genetic testing, they have two completely different risks of recurrence. Therefore, treatment of one would be different from the other because we tailor the treatments that we recommend based on individualized risk group. So with that, I'm gonna stop here today. And in the next session, I will get into nomograms, into genetic testing, and further details of all those risk groups from very low to very high for prostate cancer, and gradually get into appropriate treatment options for each risk group. Thank you very much for your attention. I appreciate it.